Cognitive Training and Memory, a narrated presentation. Alzheimer's disease is a slowly progressing neurodegenerative disorder that negatively affects language, memory, executive function, and visuospatial skills. While unlikely, the disease can start to show signs as early as the age of 30. However, most patients do not start showing signs until their mid-60s or later. Alzheimer's disease is caused by neurofibrillary tangles and amyloid plaques. Amyloid plaques are essentially hard, insoluble clamps of protein that surround the neurons. Neurofibrillary tangles are also insoluble proteins but found within the neuron. The plaques and tangles interfere with the neurons and set off a response that causes neuron damage or death in parts of the brain that involve the functions stated above. You can see the amyloid plaques and neurofibrillary tangles in and surrounding neurons in the brain in the picture attached. Cognitive training is a type of treatment used for many neurological conditions. It is often recommended when drugs are less effective in treating neurological disorders like Alzheimer's. Cognitive training and computer-based cognitive training has been shown to have beneficial results in reducing decline of cognitive function in older adults. The computer-based training is important for older adults as it permits access to treatments to a larger group of patients. Does computer-based cognitive training that focuses on language improve the baseline test scores in the experimental group patients with mild Alzheimer's disease? More specifically, does their episodic memory, delayed memory, word recognition, attention, executive function, processing speed, semantic fluency, and naming improve from the cognitive training? We hypothesize that patients with mild Alzheimer's that receive the computer-based multi-domain cognitive training with a focus on language exercises, which are performed using paper and pen, for 15 weeks will see improvement in cognitive function. More specifically, we predict that the experimental group's baseline cognitive function test scores will increase after the cognitive training. In comparison, we predict that the control group's test scores will either remain the same or show some decline due to their mild Alzheimer's. We screened a total of 106 participants with mild Alzheimer's disease for our study. Only 50 participants were included. Within the 52 groups of 25 participants were randomly assigned to the experimental group and the waitlist control group. All participants went through 7 assessments to give a baseline score prior to the study. An example of the tests administered were verbal fluency and the digit forward test. We will focus on these throughout the presentation. The verbal fluency test is a test administered to patients who are suspected of having a type of dementia which includes Alzheimer's. Patients are either given a semantic category subtest or a phonetic letter subtest. Categories include in the verbal fluency tests are often fruits, animals, etc. The most common letters used in the phonetic letter subtest are A, F, and S. Patients have 60 seconds to say as many words that fit into the subtest as possible. When a patient can't produce more than 17 words within the subtest, there is grounds for concern and further testing should be done. The digit forward test assesses short-term memory and overall cognitive function. The administrator of the test starts by reading a sequence of 3 numbers. The patient is asked to repeat the 3 numbers. The administrator increases the number of digits that the patient must remember until they make a mistake. Patients likely have dementia if they are only able to repeat 7 or less numbers. Since the training was done using a computer, participants were able to participate from home. This eliminated traveling limitations for some participants. The experimental group was given 15 weeks of computer-based cognitive training that was made up of 2 one-hour sessions per week. Participants spent 30 minutes of their sessions using a software program with exercises that focused on executive function, processing speed, attention, episodic, and delayed memory. The other 30 minutes were spent doing linguistic exercises using pen and paper. The program was based upon naming verbal fluency, word recall, morphology, syntax, and semantics. Data shows that the training group verbal fluency baseline was 22.12 versus the training group verbal fluency endpoint, which was 28.16, with an increase by 6.04. In the hypothesis, we predicted that there would be an improvement in cognitive function. For the control group, there was a decrease in cognitive function by 1.2. Like the verbal fluency test, the control group again had a decrease in cognitive function in the digit forward test. Again, the training group saw an increase in cognitive function. Multi-domain cognitive training with an emphasis on linguistics in patients with mild Alzheimer's disease showed promising results. To conclude our research, the computer-based cognitive training helped increase cognitive function of patients with mild Alzheimer's disease. A limitation in our study was the sample size. Our study only had 50 participants, so the results might not show the full effect of multi-domain cognitive training on Alzheimer's patients.